All right, we're going to go ahead and get started. If you've looked, the notes and the slides, especially the slides, actually contain chapters 20 and 21. Chapters 20 is the lymphatic system. It is not in very much detail, and so there's about for both chapters of about 205 slides. So we're going to go through half of them today. I'll stop about slide 104, 105. When we get into specific types of responses, and then we're going to go to the other slides next week, which will take us a little bit more extensive time. The lymphatic system is a very important system. Number one, when we talked about net perfusion, net pressure in the capillaries, we found that there was a pressure of 2 out. So that means there would be fluid going out of the capillaries in a normal individual. And so where that fluid obviously comes back into the body, comes back into the vascular system, and the lymphatic system is primarily responsible for that. Lymphatic system does a number of other important things, and we'll get to that in just a moment. Components of the lymphatic system, number one, the lymph. That is the fluid that's inside the lymphatic system, okay? Remember, we have fluid that's outside the lymphatic system. We have intravascular fluid, we have intracellular fluid, and we have extracellular fluid, okay? Extracellular fluid is outside the cell, which would include the intravascular and the interstitial fluid. The interstitial fluid is a fluid compartment that is not inside the vascular system and is not inside the cell. Well, there is a separate system called the lymph system and the lymphatic system, and the fluid in that system is called lymph, okay? It's the fluid from the capillaries headed back to the circulatory system, because we want to harvest that fluid that with net capillary pressure of 2 and bring it back into the vascular system. We also have a system of vessels, okay? They're not as well defined, especially in the periphery, okay? They're not as well defined, especially in the periphery. As they get towards the major trunks, you can see them, especially if they have a large fatty content in them, because otherwise they're fairly clear vessels. Collect the interstitial fluid, return it to the cardiovascular system, and lymphoid tissue and organs that house the immune systems. So the components of the lymphatic system are lymph itself, the vessel system, and the lymphoid tissue. Lymphoid tissue, lymph nodes, spleen, tonsils, a number of other things that are surveillance systems, looking for bacteria, looking for foreign material, looking for viruses, looking for cancer cells. And this is a schematic, okay, of the lymphatic system. It is not symmetrical. It's not symmetrical. The entire lower extremity and the left half of the body drains to the left lymphatic system. The right upper half of the body drains to the right lymphatic system. So it's not a symmetrical system. So if somebody has a cancer, say down, even if it's in their right groin, that when it sends metastasis, it's going to send metastasis up through the left side. It's going to send metastasis up to the left side. Remember, Lance Armstrong had testicular cancer with brain metastasis. It's not uncommon, because cancer cells would seed off from the cancer, go into the lymph system, be carried back to the circulatory system, and one of the first branches off of the aorta goes up into the cranium, okay? So it wouldn't be unusual for the person with a particular type of cancer to have brain metastasis. And so that's a particular anatomical anomaly that you need to be aware of. It drains about an average on 3 liters a day, okay? Returns leaked proteins, so if you have any leaked proteins, it's going to return those. Lipid absorption. Remember, lipids are not soluble in water. Lipids are not soluble in water. So in order for them to be absorbed, okay, in order for them to be absorbed from the GI system, they either have to be attached to some type of protein carrier, okay, or they get absorbed by the lymphatic system, then carried up into the heart, and then going throughout the system so it can get to the liver and be metabolized. So as a general rule, fats are absorbed from the GI system. So when we get to the GI tract, we'll learn about that, and we'll learn about how the fats are converted as they are absorbed from the GI system. We have capillaries, just like in any other system. We have capillaries, but these are dead end tubes. Okay, these are totally dead end tubes. That's what happens when you hit the wrong button here. And so these lymphatic vessels aren't continuous, as opposed to a capillary bed where there's an arterial end and there's a venous end. Lymphatic vessels are actually just closed in tubes that start literally around the capillary bed, because they're going to absorb this fluid that goes out, this net two of the capillary perfusion bed that we talked about in great detail in the last lecture, and then take it back into the vascular system. This is a schematic of what's going to happen when it goes back into the vascular system. We have this collection here. And it's going to go into these lymphatic vessels. It is then going to go through lymph nodes. It's going to go through lymph nodes. It's going to be filtered through lymph nodes. Okay, it's going to be filtered through lymph nodes. Remember, I talked about there being a surveillance system in the lymph nodes. And that's where some of the white blood cells are there, especially lymphocytes and macrophages, as a surveillance system. And so it's actually going to be filtered through there to try to pick up any abnormalities. They are huge openings here, okay? They have these little attachments that go out into the connective tissue that attach lymphatic vessels, because remember, they're blind in sacs. They are blind in sacs. So otherwise, because of there being fluid outside, interstitial fluid, they have a tendency to wave. So they have these little attachments here, flagellatin, and then they have valves, okay? And so they are very leaky in the fact that fluid and cells, fluid and viruses, fluid and cells, fluid and cancer cells can come into the lymphatic system. So they allow proteins, water, because of these leaky parts here. Collagen fibers attach to the surrounding structure to allow the valves to open, okay? Also collect pathogens, which could be bacteria. They collect cancer cells, and they collect cellular debris, okay? We have then, so these are collecting vessels. So we have these lymph collecting vessels, similar to veins, but thinner and much more permeable, okay? And they are, you can identify them obviously if they're filled up, but they are a very clear structure, and unless they're filled up or unless they have some way of injecting them, it's very difficult to identify them. A lot of internal one-way valves. Remember, in the vascular system, once we got to the venous side, we had valves because we had a very low pressure system. Well, this is an even lower pressure system, okay? So once we get fluid in there and get it started moving up towards the heart, remember, with the exception of the upper body and right upper body, left upper body, everything else is moving against gravity. So we had to have internal valves, just like we had in the venous system, to help us with movements, okay? We're talking about the divisions now. The thoracic duct, which is the biggest division, drains lymph from the lower body and the upper left body, drains into the left subclavian vein. So the thoracic duct drains lymph from the lower body. So we're talking about the lower body on both halves and the left upper body. That's the thoracic duct. It drains it into the left subclavian vein. The right lymphatic duct drains lymph from the right upper side of the body. So this is one of the another demonstration of the body of things not being symmetrical. And if you're looking for metastasis, because we have areas of lymph nodes that we can palpate, then you need to know what the drainage system is. Pathway is from the for lymph, okay, it's from the blood capillaries with the net2 out to the interstitial space. That is the fluid space that is either not inside the vascular system or not inside the cell, okay, into the lymphatic capillaries, into the lymph vessels, into the lymph ducts, okay, and then finally into the subclavian veins, with the right side draining into the right subclavian vein, and the lower body and the left side draining into the left subclavian vein. Driving forces, muscular pump, just like before. The lymph vessels are going to go through the muscles, and as the muscles contract, we are squeezing lymph right now. Every one of us here is squeezing lymph right now, even though we're probably sitting down. We're pushing that back towards the heart. In addition, we have the respiratory pump with the pressure changes during respiration, pushing lymph forward. Inhalation, less pressure in the thoracic cavity than the abdominal region. So the fluid would have a tendency to go, because there's less pressure, it would have a tendency to go and from the abdominal region into the thoracic cavity, just like the venous flow would. Rhythmic contractions to move muscles. Fluid moves slowly, but activity increases speed. So the faster we go, the faster the lymph flow goes. Inflamed areas benefit from massage and muscular contraction. Inflamed areas. Badly infected areas should be immobilized to decrease movement of materials and spread of pathogens. I think I may have mentioned this last time, or may have mentioned in the other class. One of the good massage therapists will always ask you before you get a massage if you have any areas of infection, because that's the last place they want to do any type of massage. Because if you have an infection, say you had an infection in one of your toes, at least it's at that particular point, it's localized to your toe. You start massaging that. All of a sudden, you're going to introduce bacteria into your lymph system. And then that's going to depend on if in your lower body, since it's your toe, that's going to go through the left side, into the left subclavian vein, but into the heart. Okay, it's going to go into the heart, and now you have a bacteremia, which just means you have bacteria in the blood. If your immune system is compromised at the time, or something else is going on, it could easily, if you were compromised, you could easily turn into a septicemia, where all of a sudden now, instead of just having bacteria in the blood, you have a full-blown infection, okay? So that is why if you have an area that's infected, you want it to be immobilized. You want it to be immobilized to decrease movement, because if you decrease the muscular pumping, you decrease the possibilities of moving stuff, and you certainly don't want to massage that area, okay? Lymphoid cells, we have primarily, we have T lymphocytes, B lymphocytes, and macrophages. And this will be next week's lecture. We mention them now, but we'll get into great detail, because the T lymphocytes differentiate into a number of types, and the B lymphocytes differentiate into a number of types. And they have a very complex interaction as to cellular immunity and antibody immunity. So we have lymphoid cells, primarily the T cells, the B cells, and the macrophages, okay? Macrophages fight cells by directly killing them, activating other immune cells, or phagocytizing cell debris. So the T cells actually have killer T cells. The T cells, they have a particular type of cell that differentiates into a killer T cell. They have helper T cells. Like I say, we'll get into that next week, but they actually go up one-to-one against another cell to try to kill that cell, okay? The B cells are going to differentiate when exposed to an antigen, okay, that is not self. You know, we have all kinds of antigens in their body that are self. We can recognize self antigens unless we have a disease state. So we don't form antibodies against self, okay? But anything that's non-self, we're going to try to get it out of us, okay? We're going to try to get it out of us. That's why that somebody who is Rh negative that receives Rh positive blood, then they see that Rh positive antigen They don't have that Rh positive antigen, so they recognize that as non-self, and they form antibodies against that, which we talked about previously. So the B cells being exposed to an antigen will convert to plasma cells and then form antibodies against cells. And then obviously the macrophages will actually phagocytize the cells and the cell debris. Lymphoid tissue is reticular tissue, okay? If you were in my anatomy and physiology 1 class, when we got to reticular tissue in chapter 4, which we've just covered in the other class, I said it looked like a bunch of grapes. And that to me is still what it looks like. We have sinuses, okay? We have reticular fibers, and then we have lymphocytes and macrophages, okay? And these are part of our surveillance system, okay? These are monitoring what comes by. These are monitoring what comes by, either looking at antigens, okay, either looking at antigens or looking at foreign material, however they can recognize it to either start a response to try to engulf it or whatever, or to actually go up against it and try to inactivate it to keep it out of our system. We have diffuse lymphatic tissue, okay, that is located in the lamina propria of the mucous membrane. Okay, that's one of the in the outermost layer. It's one of the thinner layers, but it has lymphocytes which cycle in and out of there. We have lymphoid follicles that can form and go away as needed to fight local infections. We have specific lymphoid organs. We have tonsils here. We have tonsils we have adenoid tonsils and palatine tonsils. We have the thymus, okay, which is, we'll discuss, but it's active in early childhood, and then in you and I, it has started atrophy, okay. We have the spleen, which is one of the big surveillance organs. Spleen is a big surveillance organ. That is why, if at all possible, you try not to remove a spleen, because if you remove a spleen, that takes out one of the major surveillance organs, and people are prone to infection. So they need to, if you don't have a spleen, you have to get certain vaccines, and you have to notify your dentist if you're going to have a dental procedure and get put on prophylactic antibiotics. There's a lot of things that go with having your spleen removed. We have Peyer's patches that are located in specific areas of the small intestine. And then we have the appendix, which is a lymphoid-like organ, okay? We have nodes, okay? We have 600 along the system. They are usually grouped. The largest clusters are the inguinal area, the axillary area, and the cervical region. So if you have somebody with a head and neck cancer, you are palpating the cervical region, okay? If you have somebody with a lower extremity cancer, you're palpating the inguinal region. If you have somebody that has breast cancer or a cancer of the thorax, you may be palpating the axillary region, okay? These are some of the lymph nodes we actually can feel. If you've ever had an infected tooth or tonsillitis, your nodes will swell up usually on that side of your neck, and you actually can palpate them. And whenever the infection resolves, then they will go away. But those are areas that we can palpate, okay, and that you can find lymph nodes in those areas. You normally shouldn't be able to palpate lymph nodes. They should be so small that you shouldn't be able to palpate them. Every once in a while, you might have one. I had one that hung around for 4 or 5 years. I went to a oncologist for every 6 months and got my blood work done. They kept checking it. It never turned out to be anything. And it finally just went away. And I don't have a clue why I got it, and I don't have a clue why it went away. Lymphoid organs, okay. This is a lymph node. This is a lymph node. Notice this particular thing. These are afferent. That means two. Afferent means two. Okay. Afferent means two. These are vessels bringing lymph fluid to the lymph node. These are efferent vessels. Efferent vessels taking fluid out of the lymph node. Notice you have 1, 2, 3, 4, 5. You could have more than that. Out of here, you only have 2. What that does is slow down the movement of the lymph fluid, slow down the movement of the lymph fluid. And then when you do that, you allow these areas, the germinal areas that have these surveillance cells in them, the T lymphocytes, the B lymphocytes, the macrophages, to have a good look at the fluid and the material coming by. Okay, that's the whole purpose of this, is to slow the movement of this lymph fluid down. So you have a number of afferent vessels and you have many fewer efferent vessels as the fluid comes out. Okay, filter pathogens from the lymph. Monitor the pathogens that activate the inflammatory response if necessary, and activate the immune system. Okay, activate the immune system if we're going to develop immunity against it. Okay, whether it be our cellular immunity from our T cells or antibody production from the B cells, we are going to activate the immune system. And like I say, part 2 of the lecture, which will be next week, we'll cover this particular section in great detail. Tonsils, we have 5 total. Okay, we have tonsils in the pharyngeal region. Okay, we have adenoid or pharyngeal tonsils on the posterior region of the nasopharynx. So we have tonsils up here in the nasopharynx region. We have palatine tonsils. These are the ones, the first ones are the ones if you have an adenoidectomy. These are the ones if you have a tonsillectomy. Back when I was growing up, literally every kid, we were spared. There were 3 boys in my family. We were spared, but almost everybody had a tonsillectomy. In this day and age, you have to have multiple recurrent infections before they'll think about doing a tonsillectomy. The reason being is they have now realized, that this is the first surveillance system you have for material that's going to go through the oral pharynx. And then we have 2 lingual tonsils at the base of the tongue. So we have adenoid tonsil, 2 palatine tonsils, and 2 lingual tonsils at the base of the tongue. Like I say, the philosophy on tonsillectomies has changed. They still do tonsillectomies, but not nearly as many they did as when I was growing up back in the 50s. Trap enormous numbers of pathogens. There's a sacrificial lamb. They create memory cells that find common pathogens. Remember, we take essentially our whole environment and our whole body is covered with bacteria, okay? Most of which we can fight off. We have a number of mechanisms to fight bacteria with, but we take in bacteria literally every time we, almost every time we eat, okay? Oh, the last thing was seldom lasts a lifetime because they see so many pathogens. The thymus is important early in life, only lymphoid organ that does not directly fight pathogens. We'll find out what the function of the thymus is. But it houses the T lymphocytes. What it does, it protects the T lymphocytes till they are mature enough to recognize self and non-self. So it literally takes the T lymphocytes and houses them as they mature until they can recognize self. Self is you, okay? Self is you, and non-self is anything that's not you. And so they protect them until they have that ability to do that, and they allow them to mature. And like I say, we'll get into that in more detail. We have the spleen, where there's lymph cells proliferate and receive a huge blood supply. Spleen is very vascular. Spleen is very, very vascular, has a huge blood supply. Some of the biggest blood vessels off the aorta go into the spleen because it has a huge perfusion. This is where a number of things happen in the spleen, okay? Cleans the blood, removes old and defective red blood cells, and stores platelets. And it has that surveillance function. It has some white pulp, which has lymphatic tissue, and red pulp, which has blood-filled sinuses. But we're not so much interested in the anatomy as knowing that it's one of our major surveillance organs, and also knowing it's one of the areas where red blood cells are, number one, stored, and number two, where all red blood cells go to die. Okay, they're removed down the circulation. The spleen is one of the big places of that. And so if you get a fracture of the spleen, which can be common in some traumatic injuries, you can see it in football players, you can see it in car accidents. The old method of it, if somebody had a fracture in the spleen, you took them up surgery and took their spleen out. Now, if they are hemodynamically stable, you measure serial hemoglobin and hematocrit. If they're hemodynamically stable, you do serial CTs or MRIs. And there again, I was a general surgeon back in the 70s and 80s, general surgery resident, so I don't have a clue what they do now. We used to do serial CTs and follow and see how it evolved. If it didn't bleed any further, sometimes you would just not do anything. Other times you would go in there for the wrap around the spleen. But there again, that's been a whole a number of years ago. MALT is mucosa associated lymphatic tissue and passageways open to the exterior. Peyer's patches are located in the distal small intestine, and they're set to destroy harmful intestinal bacteria. Okay. If you think about it, they're located around the appendix. They're in the distal small intestine. We do have bacteria in the small intestine, obviously, but most of the bacteria is in the large intestine. I sort of envision this. I never read it, but I sort of envision this. If you have any backflow from the large intestine, it would be there to take care of any pathogens that may be there. Okay. In addition to any pathogens that are coming down through the system. Okay. We have the appendix at the blunt end of the large intestine. In the old days, if you were going to be a missionary and you were going, somewhere where there wasn't access to medical care, sometimes some of the missionaries went and had their appendix removed. I would imagine when we start going colonize Mars, one of the people that will be there would have to be a physician who had to be a surgeon, be able to do appendectomies, because appendectomy in of itself is a fairly simple surgery, but if you allow it to persist and rupture, you can end up getting peritonitis and dying. So that would be a consideration there. You also can, one of the things we've mentioned was metastasis. Okay, spread of disease from one area to another by way of the lymph system. Okay, you not only get metastasis of cancer, which is what we think of, but you get metastasis of an infection. Okay, so you can spread it by way of the lymph system, and as you can see, once it gets in the lymph system will try to take care of it unless it's overwhelmed. Unless the tumor is shedding a ton of cancer cells, it overwhelms the lymph system, it may not be able to take care of it. Okay, we're going to start that. So that primarily was chapter 20. Okay, that primarily was chapter 20. Now we're going to start on chapter 21. And like I say, we're going to look at the general defenses. This lecture today is not going to be very long, probably just be an hour. And then next week, the lecture will be a bit longer because we're going to get into the T cells and the B cells and how they specifically divide. As far as the lab this time, it is watching one video and doing, I think, a page and a half of fill in the blank thing. So it wasn't very much. There's going to be more on the lab next week. Immune system based on the body's ability to recognize self and non-self. So you have to understand that concept. We have billions of antigens in our body that are self. Okay, we have billions of antigens that are in our body that are self. They are billions / trillions of antigens that are non-self. We need to be able to recognize self. If we can recognize self, we don't have to recognize all the trillions of non-self. All we have to do is recognize them as not self. Okay, non-self. So if they're non-self, we need to get rid of them. They don't need to be around us. It does not recognize invaders. It only recognizes self. Two divisions. We have an innate division, which is what we're going to talk about today, which is surface and internal. And then we have an adaptive, which is specific. So this is non-specific. This is for any invader. Okay. This is specific for a specific invader. We only form antibodies against a specific antigen. Remember when they're talking about the antibody test now against the coronavirus. We are developing, if you've been exposed to the coronavirus and you have mounted an antibody response, then you are making antibodies to one of the antigens of the coronavirus. So we're going to talk about the innate, which is non-specific, and then next week, since this is way more complicated, we're going to spend the majority of our time talking about the specific response, the adaptive response. You know, if the system gets through our skin, gets through the mucus, gets through our external non-specific mechanisms, then we have another way to be able to find it. Okay, so we have innate defenses, which are surface barriers and internal defenses. Then we have adaptive defenses, which is humoral immunity. Humoral immunity and production of antibodies is the same thing. Our cellular immunity. So cellular immunity is the T cells, and humoral immunity is the B cells. Innate defenses, these are non-specific. Same type of defense happens for whatever comes along. These are specific. These are adaptive. They adapt to based on what the threat is. These happen based on any threat. We have surface barriers, which are skin and mucous membrane. We have internal defenses, phagocytes, natural killer cells, inflammation, antimicrobial proteins, and fever. Okay, innate. First line defense, prevent invasion, is our skin. We have keratin in our skin. If you remember from chapter 5, the skin chapter, we have stratified on the outside in our skin. We have stratified squamous epithelium with a thick layer of keratin. Okay, with a thick layer of keratin. Inside, we have stratified squamous epithelium. Lines our throat. Okay, because we eat potato chips. Those potato chips have sharp edges on them. When we swallow them, scrape skin off, but there's not keratin there. The stratified squamous epithelium, but there's not keratin there. We also have enzymes in our skin. The skin is also acidic, and we have lysozymes in the sweat. Okay, so we have these enzymes. Okay, remember we have lysosomes in the cell. We have lysozymes in the sweat. These are some of the mechanisms that help us, okay, go to battle on the skin. The keratin, the enzymes, the acidic level, and the lysozymes. Because living things do, as a general rule, do not like an acidic level. If they're living, they need to be in an environment similar. If they're trying to invade us, if we're a carrier, they need to be in an environment of a pH of 7.35 to 7.45. If you put it in acidic pH, then that's not going to be conducive with living. Okay. Don't forget that we have a tube within a tube. If you think about it, the GI system is a continuous tube from the mouth to the anus. It's a continuous tube. The respiratory system is a blind in tube, but it's also a tube. Okay, we have an in and out in the same direction. Okay, actually, we have one way in and one way out. We have subdivision one way in, one way out with multiple cul-de-sacs on it. Okay, but it's still a connection to the outside. The same way with the GI system. Same way with the GI system. That's where the capillary beds come in and are so important, because if we just had that big long GI system, it really wouldn't do us any good. I mean, we could break down the food, but if we couldn't absorb the food in the capillary bed, okay, transfer it from the small intestine primarily into the capillary bed and take it to where it needs to go to be built into what we need, it really wouldn't do us any good. Same with the respiratory system. We can bring in oxygen, but if it wasn't for the capillary bed, we couldn't transfer that oxygen to the capillary bed and then take the CO2 that is in the capillaries and put it back into the alveolus and then send that out. And chapter 22, we'll get to the rest. For this particular module, we'll get to the respiratory system. If you happen to have done your Pearson for 2021-22, I don't know if anybody has, but if you did, I forgot to add gas exchange. So there's one more Pearson assignment for chapter 22. I think that's the only extra assignment besides the chapter test, the reading quiz, and the homework. I think there's 3 of them for each chapter, like there always is. And there's only one additional thing, and that's the gas exchange for chapter 22. Once we get to the GI system and to the renal systems, there'll be a number of extra Pearson assignments. But for those, that's the only one system, and I've forgotten added it today. So tube within a tube, organisms stop by mucus. Okay, it's like the person walking in the concrete or walking in the quicksand. The further they go, the stickier it gets. Okay, we have mucus secretions in the lungs and in the nasal cavity. We have an acidic environment in the stomach. Okay, we need an H in there. Okay, remember it's very acidic in the stomach. It's between 1 and 2. We have lysozymes in the tears from the lacrimal duct to keep microbes from settling. Okay, obviously it doesn't keep the coronavirus out because according to Dr. Burks, that's one of the ways you can get the coronavirus is through your eyes. We have secretions in our saliva, and we have our own flora which outcompetes. Okay, we have our own flora which outcompetes with the pathogenic flora because there's only a certain amount of food supply. And so if you have your own flora, that represents 99% of consumption of whatever food supply is there for the intestinal flora, it's hard for a bacterial flora to establish a foothold because there's not enough food. It's sort of like herd immunity. If you can get herd immunity for the coronavirus, which means 90% of the people have probably had the virus, they've been asymptomatic or have been symptomatic but have went through the virus and gotten well, then the virus won't have enough people to be able to spread to it, even though you'll still have 10% of the population that doesn't have the virus. Still have 10% of the population that doesn't have the virus. But because there won't be enough people for the virus to move person to person to person, then it will essentially at least go away for a while. There's nobody really knows what's going to happen with this virus, and right now we don't have a treatment, we don't have a vaccine. Inflammatory reaction. So we had our initial line of defense. Now we have our good old inflammatory reaction. Okay, what happens if it got by our initial line of defense? This is a non-specific reaction. It's the same regardless of the invader. So it doesn't matter what the invader is. Non-specific reaction, it's the same regardless of the invader. Okay. The signs of inflammation are the signs that we talked about in anatomy and physiology. One is redness. The redness is due to a hyperemia. That's an increased blood supply into the area. Swelling, okay. Swelling is due to the fact that once you dilate out, you have vasodilatation. Once you dilate up the capillaries and small vessels, then you're having more fluid come out. Heat is due to the increased blood flow, and then pain is due because you have all that extra volume in that compartment. Then the free nerve endings start firing off, and so we can explain some of these signs and symptoms based on what occurs in these particular areas. Okay, function is to limit the spread of the pathogen, to clean up the damaged tissue, and to do tissue repair. Okay, so we've got to dilate at the vessels so we can get our chemical component in there to fight against the infection, and we can get our cellular component. Cellular component is primarily the neutrophils, but also the macrophages. So we want to dilate up those vessels because those cells come out by diapedesis, squeezing through those junctions between the cells. They squeeze between the junctions of the cells, so we want to dilate up the vessels to be able to do that. And then we want to be able to clean up the tissue. Components of the cells are phagocytes. The phagocytes are the macrophages, and this is a scanning electron micrograph, the magnification 1750. How they scan it is they put a thin layer of metal. Okay, so when you do a scanning electron micrograph, you're not looking for intercellular detail. What you're looking for is surface detail. Okay, surface detail. You do a scanning electron micrograph, you're looking for surface detail because you have put a thin layer of metal on top of this and you are scanning the area. A lot of things that we have discovered have been due to, the advent and availability of new technology. Advent and availability of new technology. And it's the same with a lot of the other things. As I told you before, I was 2 years old when Watson and Crick got their paper on DNA published. So that's been in my lifetime that they just elucidated DNA, and now you literally can, swab the inside of your cheek and send it off and find out sort of, what area of the world you came from. Okay, and so you can get a DNA profile instead of months or 3 or 4 weeks. Now you can get it in a matter of a few days now. So macrophages are scavengers. Scavengers not only in the lymphatic system, but also out in the periphery. Okay, can engulf hundreds of bacteria and viruses and still survive. So you can see they're going to engulf these viruses, bacteria, and then the lysosomes. They're going to engulf these in a double membrane. The lysosome has a double membrane. It then attaches and fuses with this area, which is called a phagosome, okay? And releases its enzymes in here, and it's going to break the bacteria down. It's going to break the bacteria down and then expel the bacteria or virus or whatever it is. We will find out next week that one of the things that happens here is a partial breakdown occurs. Okay, partial breakdown occurs, and then the antigen is defined and then placed on the cell, placed on the macrophage or one of the other cells for one of the immunity cells. One of the immunity cells to combine and identify it, and then start a global immune response. And we'll find out that out about next week. In this particular thing, all they're doing is just trying to kill it. Okay, bring it in, bring it, attach a lysosome to it, kill it, and expel the parts. Okay. If there's obviously anything there, then they would utilize it, but most of the time they're just expelling the parts. They can engulf hundreds of bacteria. They also can engulf invaders and cell debris. Frequently kill in battle. Okay, all this debris constitutes pulps and exudate. This also, they talk about macrophages, but you also need to include neutrophils in here. They don't talk about neutrophils as much. Oh yeah, here they're talking about neutrophils. Neutrophils are also one of the phagocytes. They go after bacteria. Okay, we also have natural killer cells. Okay, we also have natural killer cells. We have T natural killer cells. We have another set of natural killer cells, and they're actually floating around the body looking for and killing cells with viruses and cells that are cancerous. So we have another subset of cells which are called natural. So we have the neutrophils, which go against bacteria, the macrophages, which go against everything, and then natural killer cells, which are primarily against viruses and cancer. It said that immunizations don't increase their number. So when we're looking at immunity, we're looking at cellular immunity versus humoral immunity. Humoral immunity is the production of antibodies, and immunization doesn't work to increase cellular immunity. We'll find out that once we get a set of T killer cells, okay? Once you get a set of T killer cells, they actually have a specific antigen that they go against, just like the B cells will have an antigen for which they'll produce antibodies, okay? But immunizations don't increase their number, even though they may be a specific killer cell going against a specific antigen. We also have chemical responses. We have histamine, which causes a vasodilatation. Remember, we need that vasodilatation because we need to get the neutrophils and the macrophages into the area. We have chemical when there's a infection or when there's a breach of the system, when there is a clot or when there's any kind of tissue disruption, we have chemical signals go out. We have a release of histamine. Okay, histamine's a vasodilator. The vasodilator allows these white blood cells, neutrophils here, macrophages, okay, to go out into the system, okay, go out into the system, and once to be able to fight the infection on local level, okay. We have interferon. Interferon's a unique chemical that's put up by cells under attack, usually under attack by viruses, okay? And it's put out by the cell that's under attack to warn other cells of a viral attack and to interfere with the viral replication. So interferon, if a cell is infected with a virus, it puts out, number one, it tries to interfere with the viral replication. It may or may not be able to do it. But it also sends out signals to other cells to warn them that it has been attacked by a viral infection. Interferon is one of the treatments. I don't know if they're using it against the coronavirus. There are different types of interferon, but it's one of the treatments for viral infections. We have also a complement system. Okay, complement system does a number of things. One of the things it does, okay, it either places a hole, okay, forms the pores in the bacteria. If you form a pore in a bacteria, you've essentially breached its plasma membrane. Remember, the plasma membrane is a biphospholipid layer with polar phosphate head, and that's hydrophilic, and then these lipid layers that are hydrophobic here. Okay, you have now breached that. For nothing else, you're going to have an inflow of liquid, inflow of water, because due to osmosis, water is going to go from an outside to inside because the cell is much more complicated. It's much more concentrated, the solid concentration inside the cell. And eventually, you may cause this cell to rupture. Okay, so that's one of the ways of killing the cell. Other way to kill the cell is either to deactivate it, okay, or to prepare it for the macrophage to be engulfed. So complement is, if you look in the book, there's a very complex complement system. In this particular part of the chapter, we're not going to talk about it, but one of the things it does do is there's three different pathways, okay? And one of the pathways is to form a pore in the bacteria. And that essentially opens up the cell, okay? So that puts a big hole in the side of the cell. And so you doom the cell to die, okay? And then finally, you can get a fever, okay? You can get a fever. Increased body heat result is that the body holds on to zinc and iron, which bacteria need. A lot of the bacteria like to have a fever, okay? Like to have a fever. The body fights a lot of infections with a fever, okay? The body fights a lot of infections. If a bacteria likes a fever, then the set point for what is considered in your brain as a normal temperature gets reset. So instead of 98.6, it might be reset to 101. So the body perceives that as your temperature is 101, and if you have that negative feedback, then if your normal temperature is 101, or what the body's perceiving is 101, you can see you can get into some problems. Okay, so a fever can be good to fight bacteria. It's the body's response to an infection. It's the body's response to the pyrogens being released. It also can be something. That the bacteria do, because if the body's going to hold on to zinc and iron, and bacteria need these, okay, then it would favor the bacteria to be in a warmer environment, okay. We also can get areas of an ulcer. There's a couple of areas that we can get, okay. You can get what's called an abscess. This is an area, okay, that has been walled off, okay. It's underneath the skin. That has no external orifice to drain, okay. There's no external orifice to drain. It's an area that is confined because the body, if I have a piece of pencil lead, it's probably not, it's graphite, but I don't know, maybe it might actually be lead back in the 50s when it got in there, that the body's walled off. Okay, any foreign material that's the body will wall off. Okay, so if you have an infection, the body's going to wall it off. Well, now you got a thick membrane around an infection, very thick membrane around the infection. Doesn't have a great blood supply. Okay, doesn't have a great blood supply, but it does have bacteria in it. So antibiotics don't really reach it very well. So there was an old adage when I was a general surgery resident, and it may serve you well. It may serve you well, is don't let the sun rise or the sun set on pus. In other words, if somebody has a walled off infection, it needs to be drained. Obviously, if it's superficial, you can get a syringe and a big needle. Okay, get a syringe and a big needle and pull the fluid off. And that may be all that you need to do, or just get, put a little numbing medicine in, get a scalpel and cut a little crosshairs thing, and maybe cut the tip ends off of the little points on the incision to make sure that the flaps don't come back down and seal it again, and just let it drain. And the patient will be cured. They'll have immediate relief. Their fever will go down. And it's something that's easy to treat if you can identify it. A lot of times you can't identify it. If somebody has had abdominal surgery and develops an infection in their abdomen because you have those multiple overlapping loops of small intestine, those infections may be underneath some of those loops of small intestine, and you may not be able to see it without a CT or an MRI or whatever the current state of care is. And then there's nothing to do but to go in there and drain it, and then probably take them back 2 or 3 additional times and wash their abdomen out to make sure that it doesn't recur. But if you have an abscess, which is a confined, walled off area of infection, it's going to need to be drained. Now, occasionally, if they're very, very, very superficial, they will spontaneously drain. In other words, if they're right underneath the skin, this will, it'll just one day you'll wake up, you'll be laying depends on how big it is. You'll be laying in that, you'll notice an area of drainage, and it will have spontaneously drained. But if it's not going to spontaneously drain and you're responsible for the patient, then you need to get it drained some way as soon as possible, because the patient is not going to get better unless this is drained, because antibiotics can't get to it. Antibiotics can't get to it because of thick outer membrane there. And so you can't treat it with antibiotics. That's the first time you do. If somebody comes in your office and you're taking care of the patient, you're going to put them on antibiotics and see if you can bring them back in 3 or 4 days and see if it gets better. And the thing to do, and these are just clinical tips, is you take a magic marker, and the area of redness, you draw the ring of redness right there with your magic marker. And then if they're on the wards and you're seeing them as during your clinical rotations, and you go back the next day to see them again and write your note, and that area is out, the redness is outside the magic marker, in other words, it's bigger, that means that whatever your treatment is not getting better. Okay, so those are just little tips. But if you have an abscess that's confined, it needs to be drained. As opposed to an ulcer, people with diabetes, okay, and people with vascular insufficiency, people with problems with their lymph, you can get lymphedema. You can get, if you've had a groin dissection and they have removed the lymphatic channels, okay, in other words, they've removed the big lymphatic channels that drain your lower extremity, you're going to get edema in your lower extremity. Anytime you get a breakdown in skin like this, especially if somebody has edema for whatever reason, okay, it's very hard to cure these wounds. They actually nowadays have wound care centers that specialize in wounds. But as a general surgery intern and first year resident, you spend a lot of time changing dressings and seeing these patients in the clinic, and they're very difficult patients to treat, because if they're on an outpatient basis, it's obvious they can't keep their extremity down all the time, and if they're diabetic and their blood sugar is not in good control, or they have vascular problems, they don't have good perfusion, they're just very, very difficult to treat. And so that is the lecture for today. Okay, like I said, it wasn't going to be a very big lecture.